Today's discussion is diabetic neuropathy, more precisely or specially diabetic peripheral neuropathy. Okay, so we have an anatomic and physiologic overview of the peripheral nervous system. Nervous system is broadly divided into two parts: central nervous system comprising brain and the spinal cord, leaving everything else in the peripheral nervous system. So, peripheral nervous system is a collection or network of neuronal tissues or structures or apparatus that provides a communication pathway between the periphery or rest of the body and the central nervous system. Now, what are the components of peripheral nervous system? Peripheral nervous system components are cranial nerves, spinal nerves, nerve fibers or peripheral nerves, and ganglion, autonomic ganglion or sensory ganglion. The components are cranial nerves, spinal nerves, nerve fibers comprising the peripheral nerves, ganglion, both sensory ganglion and autonomic ganglion, and then the receptors. Now, peripheral nervous system has been divided into two parts: somatic and autonomic. Both have both afferent and efferent pathways or afferent and efferent component. Now, the somatic sensory system, the afferent component is the sensory input or sensory information from the environment, and the efferent component is performed by the motor nerves. So the somatic component, if somatic division, afferent component is the sensory information from the environment, and the efferent component is the motor information provided by the central nervous system or motor system, responsible for the conscious voluntary movements of the skeletal muscles, that is the effector organ. That means this is the motor system of the of the somatic nervous system, a part of the peripheral nervous system. Then comes the autonomic nervous system. It has also got both afferent and efferent. An afferent component comes from the concentration of the carbon dioxide in the blood as well as concentration of the oxygen in the blood, or status of the BP, or composition of the content of the gastrointestinal tract, and the efferent part comes from the central nervous system. The autonomic nervous system is again subdivided into two parts, that is the parasympathetic and sympathetic division. Parasympathetic division is mainly concerned with the rest and digest response, and sympathetic division is concerned with the flight or fight response or active and alert response. In fact, sympathetic nervous system is the accelerator and the parasympathetic nervous system is the brake. The balance between the accelerator and the brake maintains the integrity or mechanical activity in the direction of the preferred destination, that means the mode of action. So precisely the central nervous system with interconnection with the peripheral nervous system. Peripheral nervous system has got two components, somatic and autonomic. somatic, motor, sensory, and autonomic, sympathetic, and parasympathetic. Basically, the functions are sensory input, motor output, and autonomic control. Now, diabetes mellitus involving the peripheral nervous system produces the insult to at any level of the peripheral nervous system known as diabetic peripheral neuropathy. What does the peripheral systems do? Connection between the central nervous system to the organs, limbs, and skin permits the brain and spinal cord to receive and to provide information to the rest of the body. Third, it has got sensory information and motor commands. And lastly, regulation of the involuntary smooth muscle movements. Now, one or another component that is also excluded in the peripheral nervous system, a part of the peripheral nervous system, or according to some authors, an independent part of the peripheral nervous system, that is the enteric nervous system. That means a part of the peripheral nervous system embedded in the lining of the gastrointestinal tract, that is known as enteric peripheral neuropathy or enteric peripheral neuronal system or enteric nervous system comprising mind plexus or orbex plexus and Meissner plexus. Minderic plexus is embedded between the two layers of the muscle fibers of the gut, that means the circular and the longitudinal fibers. Function, regulation or control of tone, intensity and velocity of movement. Second, the Meissner complex or Meissner plexus, that is the submucosal layer, is responsible for absorption, secretion, and control of local muscle contraction as well. So, enteric nervous system, an independent part of the peripheral nervous system, or a part of the peripheral nervous system, though it has got some sorts of regulation by the central as well as total sympathetic or parasympathetic nervous system. This is the enteric nervous system. Now, the neurotransmitter. In the parasympathetic division, the classical neurotransmitter is norepinephrine, except in the level of the sweat gland and the chromaffin cells of the adrenal medulla, whereas in the parasympathetic division, the neurotransmitter is acetylcholine. That means parasympathetic is cholinergic and sympathetic is adrenergic in nature. Now, the definition of diabetic peripheral neuropathy or diabetic polyneuropathy. First of all, philosophical definition, then we should go for the clinical definition. Philosophical definition means diabetic neuropathy is a descriptive term meaning a demonstrable disorder, either clinically evident or subclinical, that occurs in the setting of diabetes mellitus without other causes for the neuropathy. These neuropathic disorders include manifestations in the somatic nervous system and or autonomic nervous system. From the clinical point of view, the presence of symptoms and or signs of a nerve dysfunction in a subject with diabetes mellitus with exclusion of other causes for neuropathy. like neuropathy induced by vitamin B12 deficiency or neuropathy induced by inflammatory process like CIDP or neuropathy induced by alcohol intoxication, etc. So the presence of symptoms and or signs of a peripheral nerve dysfunction in a subject with history of or the presence of diabetes mellitus with exclusion of other causes for the neuropathy is called diabetic neuropathy. Now, the clinical impact of diabetic neuropathy, that may be painful neuropathy or there may be associated with loss of sensation, that is the loss of protective sensation. Painful neuropathy leads to impairment of the quality of life and impairment of the activity of daily living. Whereas loss of protective sensation, that is the painless neuropathy, may produce foot ulceration or Charcot neuro osteoarthropathy that may lead to cellulitis, gangrene, or even limb loss and amputation. So both the painful as well as painless neuropathy have got the impact of impairment of quality of life, disability, and obviously handicap. The ultimate result in cost and cost to the patient, that means the mortality and cost and the finish. সুতরাং ধনে প্রাণে মারা যাওয়া অর্থাৎ cost and cost to the patient is the ultimate impact of diabetic neuropathy, either painful neuropathy or painless neuropathy. Now, risk factor for diabetic polyneuropathy or diabetic peripheral neuropathy. আমি বারবার এই পেরিফেরাল পলি কথাগুলো না বলে শর্টের নিউরোপ্যাথি কথাগুলো বলে যাওয়ার চেষ্টা করব, কারণ একটা ওয়ার্ড বাঁচানো মানে একটা সেকেন্ডকে বাঁচিয়ে দেওয়া। সুতরাং এখানে টাইম বাঁচানোটাও খুব ইম্পর্টেন্ট। যেমন poor glycemic control, alcohol intoxication, hypertension, dyslipidemia, smoking. These are the modifiable risk factors for the pathogenesis of diabetic neuropathy. Non-modifiable non-modifiable factors are age, older age, sex, male sex, height, obesity, family history of neuropathic disorders, longer duration of diabetes mellitus, and some genetic changes in the angiotensin converting enzyme system and others. Pathogenesis, like pathogenesis of all other microvascular complications. The pathogenesis of diabetic neuropathy is similar, but the rheologic changes which are much more important in the pathogenesis of diabetic polyneuropathy, because involvement of the vasa nervosum part in the expansion of certain aspect of diabetic neuropathy is vital. So rheologic changes has got additional importance in the pathogenesis of diabetic polyneuropathy. Other pathogenetic factors are similar, like degree and duration of hyperglycemia, oxidative stress through reactive oxygen species, glycated advanced glycated end product, activation of the folial pathway with production of the sorbitol and fructose, chronic metabolic inflammation, activation of the protein C kinase, alteration in the blood flow, growth factors, growth hormone and insulin like growth factor 1 related axis, all are implicated in the pathogenesis of diabetic polyneuropathy. In a nutshell, glucovariability leads to all these pathological changes including endothelial dysfunction and platelet activation, as well as impairment of the micro or impairment of the angiogenesis and vascular remodeling, producing suborganellist changes like mitochondrial stress, mitochondrial damage or dysfunction, endoplasmic reticulum stress, cellular proliferation, apoptosis, and autophagy. Show metabolic, microvascular, and hemodynamic or hypoxic changes is crucial in the pathogenesis of diabetic neuropathy. So, on the basis of pathophysiologic state, classification of diabetic polyneuropathy, metabolic, microvascular, hypoxic. Second, inflammatory immune dysfunction, especially important in cranial neuropathy or diabetic neuropathy with pain and weight loss, that is the diabetic cachexia or CIDP in diabetes mellitus. Third, compression and entrapment, medial nerve compression producing carpal tunnel syndrome or tibial compartment syndrome or fibular nerve or nerve involvement at the head of the fibula. And lastly, complication of diabetes mellitus, diabetes neuropathy related to the complications of diabetic ketoacidosis, neuropathy related to the complications of the diabetic nephropathy or neuropathy related to the large vascular disease or large vessel disease, and lastly the treatment related insulin neuritis or hyperinsulin neuropathy. Show pathophysiology classification, metabolic, microvascular, hypoxic, inflammatory and immune dysfunction, entrapment or infarction or compression, complications, and lastly, treatment related. And this is the pathogenetic machinery. So, considering this diagram, we can easily subdivide it, the diabetic polyneuropathy into the pathophysiologic state. Again, I repeat, metabolic, microvascular, hypoxic, inflammation with immune dysfunction, compression, complication, treatment related. Now the clinical classification. Diabetic neuropathy is broadly subdivided into generalized distal symmetric polyneuropathy, focal, segmental or asymmetric polyneuropathy or neuropathy, and lastly combination of these two. The first, generalized symmetrical polyneuropathy, again is subdivided into acute sensory neuropathy, chronic sensory motor neuropathy, large fiber sensory neuropathy, small fiber neuropathy, and autonomic neuropathy. Small fiber neuropathy is usually associated with autonomic neuropathy. Okay, so generalized symmetric polyneuropathy subdivided into acute sensory neuropathy, chronic sensory motor polyneuropathy, small fiber neuropathy, autonomic neuropathy, and lastly large fiber neuropathy. Focal, segmental, and asymmetric neuropathy include cranial neuropathy or cranial nerve neuropathy, truncal neuropathy or lower limb or limb mononeuropathy, and proximal neuropathy involving the plexus, that is neuronal plexus in the form of lumbosacral radiculoplexopathy, producing amyotrophy that means muscle weakness and wasting. Okay, focal and segmental or asymmetrical neuropathy is subdivided into cranial, truncal, limb mono, and proximal motor. Lastly, combination of these two, that means polyradiculoneuropathy and distal diabetic neuropathy cachexia. Now, what do you mean by the large fiber and small fiber? This is the schematic diagram of neuropathy. মনে রাখা সহজের জন্য diabetic neuropathy, generalized symmetric polyneuropathy, acute sensory, chronic sensory motor, autonomic, focal and multifocal neuropathies, cranial, truncal, focal limb, amyotrophy, and coexisting chronic inflammatory demyelinating polyneuropathy, that is the CIDP. Acute sensory neuropathy. Clinical features include burning sensation, tingling sensation, or paresthesia involving the tips of the toes and lower limbs, or sharp stabbing or electric shock-like sensation. Then association with the weight loss, depression, and erectile dysfunction. Nocturnal exacerbation of the symptoms, especially the pain. Allodynia to touch and occurs in a setting of poor glycemic control. Even it may follow an episode of diabetic ketoacidosis and associated with weight loss and eating disorders. Acute sensory neuropathy, burning, fit, hyperesthesia or paresthesia or deep aching pain or sharp stabbing or electric shock-like sensation involving the lower limb associated with weight loss, depression, erectile dysfunction, and nocturnal exacerbation, allodynia to touch, and lastly, poor glycemic control or associated loss and disorders of eating. Chronic sensory motor neuropathy, the most common form of diabetic polyneuropathy. It occurs in about 75% cases of diabetic polyneuropathy. The chronic sensory motor, not motor sensory, because the sensory component is predominant, autonomic component may or may not be present, that is correlated with the severity of the diabetic polyneuropathy. And the sensory impairment is in the stocking and glove distribution, involving the lower limbs and length dependent pattern. And additional features is loss of sensation in the trunk, especially abdomen or chest, may also be noted. So chronic sensory motor, sensory predominant than motor, minor involvement of the distal muscles, sensory stocking and glove distribution, length dependent pattern, and lastly may be associated with impairment of sensation over the chest wall and abdomen. Large fiber neuropathy. What do you mean by large fiber? What do you mean by small fiber? Large fiber and small fiber usually defined on the basis of thickness of the nerve fiber. Large fiber is well myelinated and a diameter exceeding 5 micrometer, Diameter less than 5 micrometer produces the small fiber. So large fiber or small fiber is differentiated on the basis of thickness of a nerve. Large fiber is well myelinated, having greater thickness and the diameter exceeding 5 micrometer. Small fiber diameter exceeding the 5 micrometer. Number 2, function. Large fiber is well myelinated and is concerned with the function of sensory input and motor output. So both sensory and motor function is concerned with the large fiber, sparing the small fiber that is concerned with the pain and thermal sensation. So large fiber is concerned with motor and the sensory, particularly the proprioception and the vibration sensation. So large fiber carries the proprioception and vibration as well as motor command to the muscles. So the features of large fiber neuropathy are painless paresthesia at the toes and feet. Painless paresthesia at the toes and the feet. Pain and temperature is transmitted through the small fibers. That is the fibers with a thickness less than 5 micrometer. Then impairment of the vibration sensation and proprioception and impairment of the deep tendon reflex, especially the ankle jerk, because motor command is related to the corticospinal tract and comes through the large fiber. Then the ataxia, secondary to sensory deafferentiation, that means loss of proprioception or vibration sensation. Often it is asymptomatic and the diagnosis is done by the clinical test, that means testing the vibration sensation or testing the proprioception. Small fiber neuropathy, deep burning, tingling, paresthesia or sensation involving the toes and the lower limbs. Allodynia to touch, impairment of the pain sensation and thermal sensation with relative preservation of the proprioception and vibration sensation. যেহেতু motor command or motor input is not transmitted through the small fiber, so deep tendon reflexes are intact. This is the vital point. And third is usually or often accompanied by autonomic neuropathy, and lastly may develop soon after onset of type 1 type 1 diabetes mellitus. So painless paresthesia, loss of pain sensation and thermal sensation, intact deep tendon reflexes, association with autonomic neuropathy, and no motor weakness, ataxia related to the sensory deafferentiation, often asymptomatic. ওটা বলে দিয়েছি লার্জ ফাইবারের সঙ্গে। বেসিক তফাৎ হচ্ছে পেনলেস পেনফুল, তফাৎ হচ্ছে প্রোপ্রায়োসেপশন ভাইব্রেশন ভার্সেস পেন অ্যান্ড থার্মাল সেন্সেশন, ডিপ টেন্ডন রিফ্লেক্স ভার্সেস মানে ইনট্যাক্ট ভার্সেস লস্ট। তারপর হচ্ছে অটোনমিক নিউরোপ্যাথি প্লাস মাইনাস। এই প্যারামিটারগুলোর উপর বেস করে বলা যেতে পারে স্মল ফাইবার নিউরোপ্যাথি আর লার্জ ফাইবার নিউরোপ্যাথি। আগে দুটো লাইন ভুল বলেছি, স্মল ফাইবার নিউরোপ্যাথিতে লার্জ ফাইবার নিউরোপ্যাথি ম্যানিফেস্টেশন চলে গেছে। লার্জ ফাইবার উইকনেস, ওয়েস্টিং, impairment of vibration, loss of proprioception, loss of reflexes. Small fiber pain, autonomic, thermal, normal strength and reflexes, and electrophysiologic silence. Because small fibers are less myelinated or non-myelinated, but autonomic fibers are totally non-myelinated. এটা কিন্তু MCQ পারপাসে মনে রাখা দরকার আছে। Large fiber well myelinated, small fiber least myelinated, autonomic nil myelinated. Cranial motor neuropathy. Cranial mononeuropathy, third cranial nerve is the most common involvement, but third, fourth, sixth as well as seventh. আমাদের মাথায় রাখতে হবে থার্ড এবং সেভেন্থ। থার্ড নার্ভের ফিচার্স হচ্ছে এক্সটার্নাল অপথ্যালমোপ্লেজিয়া উইথ ইন্টারনাল ophthalmoplegia being intact. That means the features of impairment of the ocular muscles but sparing of the pupil, that means the pupillary light reaction. And the seventh cranial nerve palsy is also a very important features of the diabetic cranial neuropathy or cranial mononeuropathy. So third cranial nerve, seventh cranial nerve, but third, fourth, sixth also involved. Third classical features, external ophthalmoplegia with intact internal ophthalmoplegia. কেন people spare করে যায়? In third cranial nerve palsy or third cranial nerve mononeuropathy resulting from diabetes mellitus, the pupil reaction, especially light reflex, is spared. Why? ক্লাসের শুরুতেই আমি একটা কথা বলেছিলাম যে প্যাথোজেনেটিক ফ্যাক্টরস অ্যান্ড প্যাথোজেনেসিস মডিউলস আর much or less similar except the rheologic changes. সেক্ষেত্রে দুটো পয়েন্টের কথা বলা হয়েছিল, ভাসা নার্ভোসাম and ভাসা ভেসোরাম. Vasa nervosum supplies the central part of the action. The fibers concerned with the pupillary reaction or responses lies peripherally. Show the involvement of the vasa nervosum impairs the truncal portion or centripetal distribution, damaging the action, not the peripheral fibers that are concerned with the pupillary responses or reflexes. That's why third cranial nerve involvement spares the pupil in a setting of diabetes mellitus. Truncal mononeuropathy, that means neuropathy at the level of the T4 to T12, served by the spinal nerves. কি পেতে পারি? Impairment of sensation over the chest and abdomen, bulging of the abdominal wall because of the weakness of the muscles, may mimic intra-abdominal, intrathoracic or intraspinal catastrophe, or may persist several months before resolution within 4 to 6 months. Electrophysiological study is the diagnostic. It denotes the axonal degeneration. Limb mononeuropathy, that means nerve infarction or entrapment. আগেই বলা হয়েছে median nerve entrapment, বলা হয়েছে fibular nerve entrapment at the fibular head producing compartment syndrome or neuropathic syndrome. Entrapment are much more common than the infarction, and electrodiagnostic study reveals axonal degeneration. Mononeuritis multiplex, involvement of two or more nerves indicates mononeuritis multiplex that may occur at the level of the cranial nerves at the level of the peripheral nerves and may be associated with other disorders like systemic vasculitis or autoimmune diseases like systemic lupus erythematosus or other collagen vascular diseases. Proximal diabetic neuropathy, virtual involvement of the lumbosacral radiculoplexopathy, producing weakness of the gluteus and thigh muscles, as well as muscles, especially of the anterior thigh, and loss of the deep tendon reflexes. This is the asymmetric weakness and wasting, and usually associated with long-standing diabetes mellitus. So diabetic proximal neuropathy that is related to the lumbosacral radiculoplexopathy associated with weakness of the muscles of the hip, thigh, quadriceps, hamstrings, etc. and loss of the concerned reflexes develop usually in the setting of long-standing diabetes mellitus. The weakness is asymmetric and wasting is proximal. Diabetic autonomic neuropathy. অটোনমিক নিউরোপ্যাথিতে আমরা কয়েকটা ভাগে ভাগ করে নিলে মনে রাখতে সুবিধা হবে। সুডোমোটর, কার্ডিয়াক, gastrointestinal, urogenital. The first, diabetic autoneuropathy is related to the severity of the other diabetic complications. Subclinical impairment involving cardiovascular system, gastrointestinal system, urogenital dysfunction. Cardiovascular system manifestations are orthostatic hypotension, tachycardia at rest, heart rate variability to metabolic changes, and vagal denervation of the heart that is again lead to tachycardia at rest, and loss of sinus arrhythmia, painless or silent myocardial infarction. Pseudomotor, distal anhidrosis with truncal and facial hyperhidrosis. Distal anhidrosis and facial or truncal hyperhidrosis. Gustatory sweating, that means profuse sweating over the face following a meal. Pupil changes like constriction of pupil and sluggish reaction in about 20% of cases. Then blunted response to hypoglycemia, that is the hypoglycemia unawareness. Okay, pseudomotor, distal anhidrosis, facial and truncal hyperhidrosis, gustatory sweating, pupillary abnormalcy, blunted response to hypoglycemia. GI motility abnormalcy producing certain disorders, and the GI motility disorder may involve the esophagus, stomach, gallbladder, intestine, and resultant fecal incontinence. Delayed gastric emptying or gastroparesis with the manifestations of nausea, early satiety, and postprandial or prandial bloating. Diabetic diarrhea due to intestinal involvement, and diabetic diarrhea is paroxysmal and nocturnal. So paroxysmal and nocturnal diabetic diarrhea is a manifestations of the diabetic autonomic neuropathy due to small intestinal involvement. Then the colonic atony. Colonic atony leads to constipation. In fact, constipation is much more prevalent compared to diarrhea. And lastly, bacterial overgrowth syndrome due to overall hypomotility of the gastrointestinal tract. Now, urogenital impairment of the bladder sensation. This is the earliest manifestation of the diabetic autonomic neuropathy. Bladder atony, difficulty in voiding, urinary retention, and overflow incontinence. Impotence in the form of erectile dysfunction or deficit ejaculation, as well as loss of libido. And impotence is usually associated with symmetrical distal polyneuropathy. Screening. Screening should be done at 5 years after onset of type 1 diabetes mellitus and at the diagnosis of type 2 diabetes mellitus. Screening is done by touch and pressure sensation testing. আমরা প্রত্যেকেই ক্লিনিক্যাল মেথডসে পড়েছি টাচ সেন্সেশন এবং প্রেশার সেন্সেশন টেস্ট। টাচ সেন্সেশনের সবথেকে সিম্পলিফাইড মেথডস হচ্ছে ইফ উইচ টেস্ট। সেখানে সোলে 4টে পার্টিকুলার পয়েন্ট, কোনো জায়গাতে বলা আছে 5খানা পয়েন্টকে জাস্ট ইন্ডেক্স ফিঙ্গার দিয়ে টাচ করব ফর 1 to 2 seconds. First, third and fifth metatarsal heads. আর কোনো বইতে বলা আছে প্লাস the tip of the hallux. Impairment of sensation at one point indicates sensory impairment. This test is known as if switch test. তাছাড়া আর একটা টেস্ট আছে 10 gram monofilament test. So touch and pressure sensation should be done at the screening procedure of diabetic neuropathy. Diagnosis. Diagnosis is virtually a clinical diagnosis, and investigations may or may not be helpful or may be required in certain special situations. Combination of the classical symptoms as well as signs constitute the diagnosis. But in absence of signs, in absence of symptoms, the classical signs of neuropathy is suggestive of diabetic neuropathy, especially in a setting of long-standing diabetes mellitus. Now, clinical test, the touch sensation, that is small fiber function, pain sensation, and thermal sensation. Pain sensation, pinprick sensation, thermal sensation, hot water, cold water. Cold means 5 to 10 degrees centigrade, hot means 35 to 45 degrees centigrade. Cold, 5 to 10, hot, 35 to 45. And the large fiber function, that is the proprioception and vibration by means of 128 Hz tuning fork. Vibration sensation আমরা সকলেই জানি, নতুন করে কিছু বলছি না। And the reflexes, the ankle reflexes should be tested as follows. So clinical parameters to be addressed in a setting of diabetic polyneuropathy. Sensory system examination, especially the peripheral system or peripheral sensation, touch sensation, pressure sensation, proprioception, vibration, pain sensation, and thermal sensation. And the deep tendon reflexes, especially the ankle jerk. And lastly, the electrodiagnostic studies like EMG and nerve conduction velocity. And in rare cases, we should go for nerve biopsy. But tests should be done to exclude other causes of peripheral neuropathy. Blood tests for other conditions like vitamin B12 deficiency, thyroid disorders, certain autoimmune disease. সুতরাং টেস্ট should be done to exclude other causes of neuropathy. শুরুতেই বলা হয়েছিল ডেফিনেশনে with exclusion of other causes of neuropathy, and lumbar puncture may be required when confusion arising with other sorts of neuropathy. And lastly, in rare cases, nerve biopsy, sural nerve is preferred. Sural nerve action potential is usually hampered or dampened. এখন দেখতে হবে যে ডায়াবেটিক নিউরোপ্যাথি না নিউরোপ্যাথি ইন ডায়াবেটিস, তফাৎ করতে হবে ডায়াবেটিক নিউরোপ্যাথি না নিউরোপ্যাথি ইন ডায়াবেটিক। র্যাপিড অনসেট, র্যাপিড প্রোগ্রেশন, প্রমিনেন্ট মোটর অ্যাবনর্মালিটি, disproportionate large fiber, involvement of the entire lower limb, and sensory symptoms and findings in the upper limbs. এগুলো যাচ্ছে against the diagnosis of diabetic neuropathy. Repeat: rapid onset, rapid progression, prominent motor abnormality or cranial nerve involvement, disproportionate large fiber, involvement of the entire lower limb, and more often sensory neuropathy. And this is the summarized form. Family history of neuropathy: abrupt onset, asymmetrical, motor more than sensory, large fiber more than small fiber involvement, selective small fiber involvement, and foot deformity in the form of face cavus or hammer toes. And lastly, monoclonal gammopathy or other disorders may be present, or changes in the CSF protein concentration, or changes in the serological test state for some other diseases. So all these features are necessary for exclusion of neuropathy in diabetes mellitus or diabetes mellitus complicated by neuropathy. Treatment goals in short: good glycemic control, symptomatic treatment, no definitive treatment is available, and lastly, halt progression of the disease. Currently, pain, management of pain, tricyclic antidepressant, amitriptyline, nortriptyline, desipramine, etc. Other antidepressant, duloxetine. এখানে লেখা নেই, ঠিক আছে। অ্যান্টিকনভালসেন্ট, প্রিগাবালিন, গাবাপেন্টিন, কার্বামাজিপিন, সোডিয়াম ভ্যালপ্রিক অ্যাসিড, and serotonin, norepinephrine reuptake inhibitors like venlafaxine, vaccine, and opioids like tramadol. বাকিগুলো একটা লাইনে ছোট্ট করে বলে দেওয়ার চেষ্টা করছি। Pain and paresthesia, intensive glycemic control, anticonvulsant, tricyclic antidepressant, other antidepressants like duloxetine, substance P depleter, capsaicin cream, opiates, tramadol, oxycodone, membrane stabilizer, mexiletine, and antioxidant alpha lipoic acid. Then postural hypotension, supportive stockings, fludrocortisone, NSAIDs, and alpha adrenoceptor agonist, midodrine. Gastroparesis, dopamine antagonist like metoclopramide, domperidone, erythromycin, botulinum toxin, and alpha agonists like midodrine. Gastric pacemaker. Diarrhea, loperamide, broad spectrum antibiotic like rifaximin. Constipation, purgative or stimulant laxative. Atonic bladder, intermittent self-catheterization. And lastly, excessive sweating, anticholinergic drugs, propanthalin bromide, proline, oxybutinin or clonidine, topical anti-muscarinic agent. Erectile dysfunction, phosphodiesterase inhibitor like sildenafil, tadalafil, etc. or other devices like vacuum devices